Bismillahirrahmanirrahim. This is the second lecture of thyroid gland surgery. Now I will talk about thyroid surgery risks. Thyroidectomy is generally a safe procedure, but as with any surgery, thyroidectomy carries a risk of complications. Now I will talk about minor complications of thyroid surgery. Minor complications of thyroid surgery are the most common in thyroid surgery at a rate of 40% and include the following: mild dysphagia or swallowing disorders, hoarseness, a degree of voice alteration, seromas, and poor scar formation. Now I will talk about major complications of thyroid surgery. The first major complication of thyroid surgery is hypocalcemia. Incidence is 3 to 5% of thyroid surgery. Surgery can lead to trauma to the parathyroid glands or devascularization of the glands with resultant ischemia or inadvertent excision of the parathyroid glands. We are seeing here in this slide post-thyroidectomy complications. For example, hypocalcemia, the rate is 16.7%. Unilateral focal cord paralysis, the rate is 5.8%. Bilateral focal cord paralysis the rate is 1.45%. Hemorrhage, the rate is 3.6%. Wound infection, the rate is 1.45%. Hypoparathyroidism with subsequent decreased production of parathyroid hormone leads to decreased serum calcium. Acute hypocalcemia generally present at 24 to 48 hours as laryngeal stridor and airway obstruction. First symptoms of hypocalcemia are usually tingling in the lips and fingertips. Additional findings may develop, including carbopedal spasm, tetany, laryngospasm, seizures, QT wave prolongation, and cardiac arrest. Zvostik's sign is facial contractions elicited by tapping the facial nerve in the parauricular area. Trosso sign is carpal spasm on inflation of a blood pressure cuff. Continuous positive airway pressure is often effective for associated airway compromise, and 1 gram of calcium gluconate given slowly usually alleviates spasm. Manifestations of hypocalcemia: weakness, tetany, positive trosso and Zvostik sign, laryngeal stridor, dysphagia, tingling around the mouth or in the extremities. We are seeing here in this slide complications post-thyroidectomy. For example, temporary hypocalcemia, the rate is 3.75%. Permanent hypocalcemia, the rate is 3.75%. Temporary recurrent laryngeal nerve injury, the rate is 5%. Superior laryngeal nerve injury, the rate is 1.25%. Seroma, the rate is 1.25%. We are seeing here in this slide complications post-thyroidectomy. For example, hematoma, the rate is 2%. Recurrent laryngeal nerve palsy, the rate is 6%. Superior laryngeal nerve palsy, the rate is 2%. Hypoparathyroidism, the rate is 14%. Hypothyroidism, the rate is 2%. Wound infection, the rate is 2%. Seroma, the rate is 2%. We are seeing here in this slide complications of thyroid surgery. The minor complication of thyroid surgery is post-operative surgical site seromas, poor scar formation. Major complications of thyroid surgery is bleeding, injury to the recurrent laryngeal nerve, injury to the superior laryngeal nerve, hypoparathyroidism, thyrotoxic storm, infection, hypothyroidism. The second major complication of thyroid surgery is airway obstruction, comprising hematoma, tracheomalacia. Incidence of hematoma is less than 1 to 2% of thyroid surgery. Tracheomalacia incidence is less than 1% of thyroid surgery. Acute airway obstruction from hematoma may occur immediately post-operatively and is the most frequent cause of airway obstruction in the first 24 hours. Definitive therapy is opening the surgical incision to evacuate the hematoma. Reintubation may be life-saving for persistent airway obstruction. Consider awake fiber optic intubation. The third major complication of thyroid surgery is recurrent laryngeal nerve damage and dysphonia. Incidence of injury is 0.77% for unilateral damage, resulting in hoarseness, and 0.39% for bilateral damage with associated aphonia and airway obstruction. The fourth major complication of thyroid surgery is superior laryngeal nerve injury. The external branch of the superior laryngeal nerve is involved with the branches of the superior thyroid artery in a critical area 1.5 to 2 cm from the thyroid capsule. The external branch of the superior laryngeal nerve is the most commonly injured nerve in the thyroid surgery, with an injury rate of 0 to 25% of thyroid surgery. It is innervated cricothyroid muscle. This muscle is involved in elongation of the focal folds, and trauma to this nerve results in the ability to lengthen the focal folds and leads to high-pitched sound. In this slide, we are seeing here superior laryngeal nerve paralysis. If bilateral damaged, patient can't elevate pitch. If unilateral damaged, one fold elongates for pitch change while the other is unaffected, results in hoarse voice, lacking pitch variation, and adequate loudness. Result is an oblique glottis. The fifth major complication of thyroid surgery is wound infection. Incidence is 0.2 to 0.5%. Treatment: antibiotic. Drainage is an important part of a treatment. The sixth major complication of thyroid surgery: bleeding. Bleeding after thyroidectomy. Rebleeding occurred in 2.1% and was associated with older age and male gender. The seventh major complication of thyroid surgery is hypothyroidism. If the patient have a total thyroidectomy or the entire thyroid gland removed, the patient will require prescription thyroid replacement therapy after their procedure. The eighth major complication of thyroid surgery is thyrotoxic storm or thyrotoxic crisis. It is a life-threatening condition that leads to excessive release of thyroid hormones in patients with thyrotoxicosis. It is an unusual complication that may result from manipulation of thyroid gland in patients with hyperthyroidism. Thyrotoxic crisis can occur pre-operatively or during the surgery or post-operatively and can be prevented by preoperative management with anti-thyroid drugs. If thyrotoxic crisis occurs during thyroid surgery, the surgeon should stop the procedure, and beta blockers, propylturacil, sodium iodine, and steroids should be administered intravenously. The use of cooling blankets and cold intravenous fluid are essential for reducing the patient's high body temperature. In the end of this lecture, Thank you for all.